So welcome everybody to our CNR event. We've got our fabulous Jenny Crow who's coming to talk to us today about minor stroke and minor problems. So it's going to be a really interesting and clinically relevant talk for us all. I'm going to do a little bit of background on Jenny Crow. So she's a clinical academic occupational therapist with over 20 years experience working with people with stroke and their families. She was awarded an NIHR grant, pre-doctoral fellowship in 2020, which followed by getting an NIHR clinical doctoral research fellowship in 2022. And has recently completed her PhD, which I think a lot of this work is on your PhD, isn't it? Her doctoral research focused on developing and testing personalised follow-up care after minor stroke, and she's a member of the European Life After Stroke Scientific Committee and leads a stroke patient public involvement group. Her current research focuses on improving the engagement and representation of underserved communities in stroke research. I didn't know that's amazing. To strengthen resilience and equity and generalisability of your findings. So we want a big thank you for you coming today, Jenny. Thank you.
Right. Thanks, Kate, for the invite. Thank you, everyone, for coming on a very hot, but this is a nice, cool room evening. I just want to get a sense of who in the room is purely clinician. And clinician researchers? One? Okay. And lived experience? One. Okay, great. Okay, that just helps me because that's kind of the audience I was sort of pitching to. So I guess the only thing to add to what Kate said is that I'm working here at Queen Square 2 days a week. I have a job share with Nicole on HASU and ASU, so that's brilliant for me. Okay, that one's not working. So basically, there are 3 takeaways that I deliver to you today, which I hope will be useful and interesting to you. The one I'm going to talk about is just about as I tell the story of how I got to the research project, sort of my journey from being a full-time clinician to doing research as well. I'm going to talk about the patient and public involvement work I did and why I think we need to be better at it in the clinical setting as well, not only in research. And then talk about the mixed methods feasibility study. So, quick background, 1 in 4 of us, according to the World Stroke Organization, will have a stroke in our lifetime, so that's quite a lot of us in this room. Strokes are very expensive. They cost society a lot of money, they cost governments a lot of money. And in many cases, strokes can be prevented. So there's good evidence-based interventions for a lot of the risk factors for stroke. But despite that, stroke in people under the age of 55 is still increasing. And those data are from the South London Stroke Register. So we can't feel comfortable that that's in a different continent somewhere, that's here. And there's been no decrease in secondary stroke since 2005. So this is kind of where my journey started. Well, it started before that, but in 2009, stroke services in England were reconfigured, and we had the formation of these 8 hyperacute stroke units across London. And the idea was that anyone who was suspected of having a stroke was blue lighted into one of those units so that they could have access to 24-hour thrombolysis. And now that's 24-hour access to thrombectomy in some of the units as well. And from a therapy perspective, suddenly there were these performance standards that we were being measured against, which we hadn't had before. And basically, we needed to see everyone who'd had a confirmed stroke, even if it was a minor stroke. So we do a quick assessment, physical assessment, a cognitive assessment, maybe a multiple errands, maybe up and down the stairs. And then we kind of conclude they're back to baseline, they're okay. And they get sent home maybe with a 6-month review. And so we were worried that we were missing people with the higher level cognitive impairments were the focus. And we thought, these little assessments that we're doing, does that really mean someone can go back to a busy family life, a busy role, a busy job or whatever? So I started just phoning people up. sort of 6 weeks after they left to see how they were getting on. And this first guy that I called, he was actually a GP, and we saw him in our service, and he said, I wasn't doing anything really on the ward. I walked to the bathroom, I had a few brief conversations. He didn't even have a shower in the time he was in. And then when I got home, I had problems with coordination, shampooing my hair, knife and fork, walking longer distance, and he didn't feel he could go straight back to work. So that's actually what he's describing as like physical problems that we've missed there. And he also didn't go, I don't know if he ever went back to work, but at 3 months he still wasn't back at work. And the next quote was from a lady who put in a complaint. So she went home, started doing things, thought, I think I've had another stroke. Phoned her GP. GP said, contact the stroke unit. Contacted the HASU. The HASU said, if you think you've had a stroke, go to A&E. And so she was just sent around the place, or the houses. And again, she said, I wasn't doing anything in the hospital that allowed me to flag up that I had these problems. The first time I cooked at home, my brain wasn't ready. It's not just about the mechanical. I needed to learn to split my brain. So a lovely lay description of sort of multitasking and suddenly finding that very difficult. Said more succinctly was another lady who basically just summarized her experience of getting home like that. So we attempted to address it I did a joint project with one of our local community services where their stroke support workers followed people up at 2 weeks. We did it for 3 months. We found that about half of the people had unmet needs at that point, mainly around mood and information provision. And then myself and one of a stroke consultant set up a post-stroke cognitive clinic, because I kind of thought that, I think this is about cognition. I think this is why people aren't remembering what they're told. They're saying they weren't told anything. And so we followed people up at 6 weeks. And again, a third of the people we followed up weren't back at work. And there were a whole lot of problems that we came up against. But we couldn't we couldn't get funding for any of it. So it was all stopped. And basically I felt like I'd hit a brick wall, although not only me, but the other people who were also interested in this. So that was where I thought maybe research is the way in, because if you've got an evidence base, then you might be able to convince people to change what they do. So these were the 2 fellowships that I did. And once you have a fellowship, it gives you time to do some reading and to actually start searching the literature, because I know as a clinician it's very difficult to find time. It all has to be done after work when you're feeling really tired. But what the literature told me when I did the literature review was exactly what the patients had been saying, that they've got all these unmet information needs, they're experiencing hidden impairments, and they can't access follow-up care because the GPs say they're too good. You can't just walk into a hospital, you've got to go via A&E. And this was well summarized in the World Stroke Organization in 2008 spoke about little strokes, big trouble. And I thought that was a very nice summary. And this guy, Ovid, he was also speaking about it a long time ago, not necessarily in the context of this specifically, but act before diseases gain strength. So anyone who's had a minor stroke is at increased risk of further stroke. And so that's the point at which, in a way, people are ripe for behavior change, for understanding what's going on. And disease gains strength if people don't take their medication, don't change their lifestyle, and so on. There's quite a lot of different terminology that's used for minor stroke, so you may be familiar with some of those in the literature. Stroke syndrome I've only seen on discharge summaries, but I haven't seen it on anywhere else. And then there are 2 main definitions, which is the time-based definition, which says if your symptoms are fully resolved after 24 hours, you've had a TIA. The tissue-based, which says even if you feel like your symptoms are fully resolved, if there's something on the imaging, some sign of tissue damage, then you've had a minor stroke. Everyone will be familiar with this, the NIHSS. So if a minor stroke, your score would be between 1 and 5. And in research, they're sometimes even stricter, and they're limited to people with a NIHSS of less than or equal to 3. But we also know from the literature that you can have an NIHSS of 0 and still have some disability. And again, there's been research that's done following people up, and the one that I really wanted to highlight was the Karanen paper, where they followed up people of working age, and they had a healthy control group, sort of age matched, and what they found was that 41% of those people showed cognitive deficits at 6 months. That was with proper neuropsychological testing. The inter-rater reliability is not great for the NIHSS, which is interesting because the more experienced the clinicians they found, the worse it was. And I think that's probably because the experienced clinicians take shortcuts. And it's not sensitive to all strokes. So if it's an anterior circulation stroke, you're more likely to score higher, whereas a posterior circulation or brainstem stroke or a lacuna stroke, which many of the minor strokes are, you might have a score of 0. So that led on to developing my research proposal. And my second takeaway message is around patient and public involvement. I set up a patient and public involvement group, so people who'd had a minor stroke. I invited about 14 people, 6 people were happy to take part. And together, over a period of a year, we met 4 times in that year and started to develop what the follow-up intervention would look like. In my mind, I had what I thought it should look like, but they changed my view on that, which was really useful. And they also looked at the outcome measures and the theory that was underpinning the intervention, and gave feedback on that. So it was really helpful. One of the big take-homes for me was that they really hated the term minor stroke because they felt it sounds like it's something that's benign. It's not something that's benign. It's a serious warning that that something bigger could be on its way. And they also said that if we're trying to convince people to stop smoking, stop doing the things that they like, and you say, but it's only a very not serious problem you've got, that's not really going to work. But the problem that I had was that stroke doesn't affect everyone equally. And my patient participant group were all bar one person white, educated, the usual people who take part, basically. And we know from this literature review that the Stroke Association did, and we just know from clinical practice, from who we see on the ward, that strokes don't affect everyone equally. And people from the lowest socioeconomic groups will have their stroke 7 years before people from the most affluent communities. Low levels of literacy are a risk factor for stroke, just being poorly educated. And then there are non-modifiable factors like ethnicity and people who have English as a second language, which certainly here and many of probably all the London units, there are lots of people who don't speak English, and that again leads to poorer health outcomes. So I did community outreach work. So I went out to underserved communities. The first one was a group of refugee women called the Mosaic Community Trust, and did work with them on understanding what they understood about stroke, what they understood about recovery. I learned lots from them. Then I went out to Harrow, which also has a very diverse community, did like a thing in a cafe. I was wearing my uniform there because I was told that if I wore my uniform there, people would believe me more. They would trust me more. So that was why I was wearing my uniform at a cafe in Harrow. And then the last one was an online group, which I did with Julie, who's a person with lived experience, and with Dr. El Mamoun, who's one of the stroke consultants at Chell West. And that was amazing because we had Julie there, the community that we were talking to, there was just a level of, an improved level of trust that I hadn't seen in any of the other groups. And so there were conversations around views on psychological support and how they as a church community viewed that, and things that I think wouldn't have happened if she hadn't been there. So I learned loads from them. They looked at my participant information sheet and my consent form and helped me to develop an accessible participant information sheet. I learned from the Mosaic community why they think people have strokes, how they think people recover from strokes, which, by the way, is not what any of us think or know. And then that really impacted how I approached my recruitment in the study I did. And what was clear is that the communication that people receive in our clinical services and research privileges those who are well educated, digitally literate, time and resource rich, and English speaking. So this is just an example of my participant information sheet. It's 7 pages long, has to be 7 pages long. That's only 3 pages. But with input from the community group, I was able to make this like really much more accessible. And I actually used it for lots of people because no one wants to read 7 pages when you're on a HASU. Well, actually, not even just on a HASU. Okay, so then I moved on to my mixed methods feasibility study. So before I started the study, I did a scoping review just to make sure that there wasn't somewhere in the world where they were already following up people with minor stroke and that they demonstrated that it had worked. I found 25 studies that I was able to include, and most of them, the follow-up was mainly education and exercise groups. There was much less focus on hidden impairments, the sort of psychological support side, very little about how families were involved and how primary and secondary care worked together, because at some point, you have to kind of hand people over. And the interventions themselves were very poorly described. There was no health economics analysis. So I was confident that no one has sort of cracked this nut yet. I don't know if people are familiar with this, but this is a MRC NIHR framework for developing complex interventions. So all the stuff that we do is generally a complex intervention. It's not just giving a pill and making sure someone swallows it, because it's multi-component. You have to think of the social context that the person's in and all these kind of factors, which means everything we do, we're sort of adjusting as we go to the person in front of you. And you can see the core elements there, which are around context, developing a program theory, which I'll show you one that I developed, stakeholders, what are the key uncertainties, and then continuing to refine the intervention and think about the economics and actually measure that. I had to, as part of developing the complex intervention, you need to identify a theory that underpins what you're doing. And I used self-determination theory, which basically posits that we all have these 3 basic psychological needs for autonomy, competence, and relatedness. And if you think of the experience of being on a hyperacute stroke unit, where you have no autonomy, you don't understand what's going on, you feel like an imposter because there's some really sick people around you and you think maybe you shouldn't actually be there. And the theory says that if we can support those aspects of people's psychology, then they're likely to be more engaged. So the goal of my intervention was to support people to feel like they'd regained control, rebuild confidence, and prevent further strokes and reconnect with meaningful life. So this is the program theory, which looks really complicated, but just in summary, the blue column is what were the behaviors that the intervention was targeting, which you can see listed there, which kind of aligned with the literature as well. And then the intervention components, so that maps out how, why, under what conditions will this intervention produce its intended outcomes. And then the outcomes are in the purple column there, but I won't go through it in detail. I also developed something called a TIDIA checklist, which is basically where you describe what the goals of your intervention are, exactly what the steps are, who's going to do them, where they're going to do them, when they're going to do them, how many times they're going to do them, how much can they tailor and change the intervention. And that then enables other people to look at that and either replicate it or decide how they want to adapt it. So that I published on Open Science Framework. And I also developed a training manual which sort of covered the knowledge and skills that someone would need to do the follow-up intervention. And in my mind, I envisaged that it would be done either by nurses or AHPs, so any of the AHPs. And then I was ready to start the feasibility study, so you can kind of see the flow diagram there. So those who had the intervention were followed up at 2 weeks and 6 weeks, and then both groups had their outcome measurements at 12 weeks. These were my inclusion and exclusion criteria. No real surprises there. Just for inclusion, they had to have a radiological, or for those people who couldn't have MRI, if the consultant had said, this is a stroke, then they were included. And their NIHSS had to be 0 to 5 at 2 hours. And I'll talk about that again in a bit. And also the other thing was no onward referral. So I didn't want to be seeing people who are already being seen in the community, because what people were telling me is there's this group of people that we think are too good to refer on, so we don't refer them on, and those are the ones I was trying to follow up. And the exclusion criteria, I didn't have English as an exclusion criteria if the person had a family member who could support them, but I didn't have money for translators, so I did manage to get that through ethics. So with a feasibility study, basically the purpose of a feasibility study is to say, can this actually be done? Because that makes no sense to do a big multi-center randomized controlled trial that actually fails, from the outset. So this is like the first step. So basically you're looking at what proportion of those who meet your inclusion criteria agree to take part, how many do they agree to be randomized, if they say yes, and they're in the intervention group, do they stick with the program, and then how many are retained at 12 weeks for, come back or participate in the outcome measurements. And I also had lots of secondary feasibility objectives. I was very interested in the demographic of the people that I recruited. Also looking at the outcome measures. I'm not going to talk about all of them, but I'll mention return to work, how people wanted to be followed up, and then also the qualitative interviews that I did at the end. So when you do a feasibility study, you need to set the progression decision criteria before you do the study, because it establishes the measurable thresholds that inform the decision whether to progress to a definitive trial or not. So you can see here, if you just look at recruitment uptake, what I said was that if 90% of the participants agree to take part, then that means that from a recruitment perspective, one could proceed to a full trial without any changes. And if they fall into the amber, then it means you might need to make some changes. If it falls into red, it's probably not going to fly. And those are also based on preliminary data gathering that I've done, and then looking at other feasibility studies in the same space to get an idea of how to set it. I then recruited people from the hyperacute stroke unit and the TIA clinic, because obviously some of those people end up being strokes as well. They were randomized by sealed envelope and were also stratified by recruitment location, so I had an even spread of where they came from. Those are just the last 2 pages of my participant information sheet, which was the accessible version. And then, because it was a mixed method study, I had to sort of identify what mixed methods I would use. So I used what's called an explanatory sequential design, where you start with the quantitative data, and you use that, you analyze that data, and that you use that to inform your sampling strategy for the qualitative interviews, and also the questions that you're going to ask in the topic guide, because things will start coming up as you're doing the quantitative data analysis. And then you do your qualitative interviews, and then you try and combine the data to kind of, if you like, put the meat on the bone. So if something went well, is there anything that people said in the qualitative data that tells me why it went well, or if it went, or vice versa? So these were the outcome form. So I actually recruited ahead of target, which is really unusual for stroke trials. And I think that's because I was a clinician. And so I'm like everyone in this room, we're good at talking to people, and we're good at reading people and knowing when to back off. You understand the rhythm of the ward, so when not to go in and all that kind of stuff. Anyway, there were only 6 people who declined to participate of the 68 people that I approached. And I had 2 dropouts. So one in the intervention group, and the other was someone who was in the control group and had sort of personal stuff going on. He was caring for his mum. This is sort of a description of who took part. So the age, sort of early 60s, was the mean age. Only 30% of my study participants were female, which is a big problem in stroke research. Although strangely, the people who said no, it was an equal split of men and women. But I think that it also brings in the question about women having bigger strokes, but later, possibly. Mainly ischemic strokes, most came from HASU. The NIHSS on admission, the median was about 2. Most people were independent before their stroke. You can see the hyperacute interventions that people had. And more than half of the study participants in both groups were working at the time of their stroke. In this box and whisker plot, you can just see that those numbers are study participant numbers, but you can see that, this number 45, he had an NIHSS of 18 when he came in, but he had a thrombolysis and a thrombectomy, and within 2 hours he was down at 5, and you can see the other outliers there. People had short stays, as we would expect, so mainly 1 to 2 days. In terms of the demographics of my study participants, what I did was I looked at the census data from 2021, and in London, 46%, just over 46% of people identify as something other than white, basically. So I then looked at my participants and how many of them identified as something other than white, and it was 40%. So less than the London split, but good for research generally. So I was very happy with that, and I really think that was because of all the other work I did beforehand. In terms of the outcome measures, these were the measures that I used, which you can see listed there. The third one is a measure of self-determination, so measuring whether you actually have used all the techniques correctly. And the PROMIS 10, I don't know if people are familiar with it, but it's a quality of life measure that's a bit more detailed than the EQ5D. And you can divide it into mental health and physical health, and it has normative scores, so it's quite useful. The ones that no one liked was the SDT outcome measure. So if we were to do another study, we would need to look at a different measure for that. Sorry. What was interesting is that at 12 weeks, less than half of the people were back at work. And these are people supposedly had a minor stroke, and we might have said we're back to baseline or nearly back to baseline. So that's really a significant number. Also, what was interesting to me is most of them wanted face-to-face appointments. I did offer either for them to come in, or I went out to them. And as you can see at follow-up, 87% wanted a face-to-face appointment. I'm just going to drink some water. And I think the qualitative interviews helped me to understand that a bit. Wow, that number's so high. So with the qualitative interviews, I interviewed 19 people, and you can kind of see the description of age range and so on there. And the interviews were imported into NVivo, which is a data management software. And I used something called, something called reflexive thematic analysis, which is it's one of the 3 sort of thematic analysis types that Braun and Clark describe. But it's quite interpretive, and you kind of go be under the meaning of what people are saying to try and look at where the patterns of meaning are within the data, where they conflict, and from that you develop the themes. So these were the themes that I came up with. There were 3 of them, and then with the sub-themes underneath. And they kind of went along the pathway. So you had shock and the unknown in hospital, adrift and in the dark when they first got home, And then some people are fine and some people aren't. And I was really trying to unpick who is fine and who isn't, and what is it that makes some people do okay and others not. So that was the third theme. So the first one was people were just, they weren't, most of the people were not expecting to have a stroke. The first guy, he said, I just didn't think it would happen to me. He was really fit. He went to the gym 2 hours a day, not overweight, healthy lifestyle. And he was one of those high scores, actually, as well. And then the next quote was from a young woman who, as you can see, wasn't English speaking. But she said, how can I make a stroke because I'm very young? And she just didn't understand that because she thought it happened to older people. And the last one was also, someone saying, what the hell has just happened? What is going to happen and when am I going to get better? And then that sort of shock and not understanding what's going on is exacerbated by cognitive changes early on and the way information is provided. So the first guy, I actually went to recruit him, and he'd had a thrombectomy, but he didn't know that he'd had a thrombectomy, so he was already on HASU. And he wasn't sure if he'd had the operation or not, which I was really shocked by. And he said, my head wasn't clear. And then the second quote was from a guy who's the son of a second language English-speaking patient. And he sort of described how his dad was trying to tell him what the doctors had told him on the round, but he said he's forgotten all of that, and then no one else is there when the doctors come around to hear that information. So the father has to understand it and recall it. And that same son then went on to say he just felt that the teams are numb. We've just stopped kind of caring about the stuff. And I feel like they just assume they explain something once and that's it. The second quote was a woman who came at visiting times. Doctor's door was closed. She tried to get answers. No one would speak to her. She said they didn't have time to answer questions. And then this is also the thing about how information is communicated. And this was a daughter, again, of a patient saying, I think that they don't consider that we don't have the same backgrounds as them. And they forget the human element. So it's not simply presented. And those are the people who haven't had the strokes. They're the family, they're the well ones. And then once people go home, they are really afraid that they've had a stroke, that they're going to have another stroke. And as they start to do more, they think they have had another stroke. Generally speaking, accessing a GP was a complete nightmare for people. And there's a lot of the GP will do this, the GP will do that, but apparently they don't. And when you do get to see them, obviously the appointments are very short. The thrombectomy guy that I was talking about, he didn't even have a GP. And so he registered one, he got the NHS app, but then he didn't understand the results, what was on there. And so literally sat with Google, kind of Googling the words and trying to understand what had gone on. And then the impact of their stroke starts to really hit home. So fatigue. The second quote is a woman where she describes herself in her kitchen and says, she's the same person, but it's like two different things. She doesn't feel the same in her kitchen anymore. She can't do what she was doing before. The next quote is a guy who spoke about the pharmacist calling him to talk about his medication and just getting bombarded with information. And he said, you just can't take it all in. And the last guy was a hairdresser who had gone back to work but was only seeing 1 to 2 clients a day. So obviously if you've got a mortgage to pay, that's going to become an issue. And then the last theme was people really valued being given time and being listened to. And just going in and the first quote is from the guy who didn't know if he'd had his thrombectomy or not. And I went in there and I sat down and introduced myself. I needed to establish if he knew he'd had a stroke, because a lot of the people I went to didn't realize they'd had a stroke. And just that process of sort of explaining to him, no, you have had a stroke, this is what's happened, made him start to feel calm. So it was just about being able to spend more time with him. People found that in the intervention group, having this point of contact really helpful. And also having time, because it's so overwhelming on HASU, you don't really know. You just don't know until you go home what's actually going on. And then also interestingly, in terms of people who did get follow-up care, their experience was generally therapists saying, we don't know what to do with you, you're too good, you're too high level. The second quote, she had private OT, private physio, private speech, and she said, they don't know what to do with me, but it took her a year to get back to work, so she wasn't back to baseline. And the second was also this, or the third one is also about the lack of psychological support. So some people have really positive mindsets, and those were the people that generally, as you'd expect, seem to do better. You need to move on, not turn your head and look back. Also, having personal agency. So that the young woman who thought that strokes didn't happen to young people, she'd believed that that moving would help her to recover, and she was a cleaner, and she was back at work within like 2 weeks. And she said that her left side was quite weak, but she thought it was better for her to move and make the things I was doing before. And then also some people just were worried about getting back to work, supporting their families. The first guy had a young family, 3 kids. His wife is a Band 5 nurse. He was an HCA, and he just wanted to get back to work to be able to support his family financially. And then there was another guy who was in a kind of high-paying job, really supportive employer, and at 6 months was still being paid his full salary, even though he'd only just started going back to work. So again, different contexts. And a lot of people spoke about having doctor friends, and doctor friends being called to, sort of decipher the discharge summaries and things like that. So sorry for the doctors. What I did demonstrate with the feasibility study, that it would be possible to roll this out and do a bigger sort of multi-center study. I was able to recruit and retain people. And also what we saw was exactly what the literature had said, that personalised information and support needs are not being met across the pathway, but not just in the acute setting, all the way along. And so some thoughts and recommendations I had was one around ward visiting policies, and the fact that the time that people are given the information is when the family are not there. And I know that families can be a pain, but if you had just one family member who understood and could be present, then it would save these families frantically trying to find information when their parents or whatever can't give them any updates. And there is this mismatch between what people are told and what they retain. So I think there's lots of stuff that aren't told, but I know for a fact with some of them, because personally I told them, and then when I followed them up, they hadn't retained it at all. So I think we need to think about, is there a way we can maybe provide that in different formats, make it something they can go back to. And even though they look fine and they might be sitting there on their laptop or with a cup of coffee, they're shocked and they're afraid, and they don't know why they don't want to be there. Secondary prevention, again, we could probably do better in acute and start addressing things like more active people. A lot of people were really afraid to go back to exercise, so they were afraid they'd have another stroke. And maybe also improving the patient, but family members as well, better for the difficulties that someone might have, even though we haven't picked them up, in the hospital. And in an ideal world, you'd have AHPs and nurses integrated into the medical follow-up so that those that needed our input could get it. There is a stroke 6-month review, but only like 40% of people actually get it. And it's mainly white British people who get it, which is something around, people not engaging with services. But maybe the people who who would find the answers anyway are the ones that are getting it. So I think that people do need to be reviewed, and it needs to be like a holistic review at 2 weeks. And then what I found with the review that I did at 2 weeks, people were just focused on like questions around their medication. Do I have to take this for the rest of my life? Do I have to order? Do I need to get more? All this basic stuff they just hadn't remembered. And things like they said I was going to have a cardiac appointment. I haven't had a letter, all this kind of stuff. Wouldn't it be great if our minor stroke patients could go to cardiac rehab groups? They have the same risk factor profile, but they generally aren't accepted, as well as other community groups like diabetes groups, exercise groups, all those kind of things. GP performance is measured by something called QOF targets, and for stroke, it's about whether they've prescribed, for someone with hypertension, they've prescribed the medication, and AF, they've prescribed the medication. But there's nothing around, it's one thing to prescribe the medication, it's another thing to check whether someone's actually taking it, and then making the lifestyle changes. So we need more people in the community, basically. Whose responsibility is it? Because this was one of the problems for me with the service thing right in the beginning, was when I spoke to our kind of our managers, they were like, it's a community problem, it's not our problem. They've left us, they need to deal with it. But actually I think it's not quite as black and white as that. And I think there needs to be shared ownership, particularly for the first follow-up, because the questions are so related to exactly what's happened in the hospital. And if you can't access the medical notes, you've got a fairly badly written discharge summary. That's all you've got to refer to, and a fairly briefly written referral. It's very hard to address all the questions that people have. So just to finish off, I hope I've convinced you that a minor stroke is not minor, and anything that impacts that list of things there is not a minor thing. And then just thank you to my funders, my PPI group, my study participants, and my supervisory team. And I'd welcome any questions.
I just want to thank you, Jenny, for such insight into patients that probably we get home from HASU really quickly. And that's been a really amazing talk for us to think about how we do a bit of PPI, or think about how you change, making sure people can have more support. It's a really important part of your research, isn't it? It's really insightful for all those people that have been on HASU and discharged people because they're back to baseline. So I think we should really think about how, particularly those patients that potentially you've said are good for go back to work, no problems, no impairments, and then they don't get back to work and they lose their job. So there's that kind of interaction. So well done, that's an amazing piece of work.
Yeah, I mean, I think also just to say, not to make all the acute therapists in the room
so let everyone go home.
Yeah, and suddenly our length of stay goes up. I thought before I started this whole thing that the problem was us, that we weren't doing proper assessments. But what I actually think now is it's too soon on the HASU to do assessments, and that actually
4 weeks later.
If someone gets 16 on the mocker, or if they're walking around, you're not going to keep them in anyway. They're going to go if they've got family. So now I think there are things we could do better, but it's less. We can't challenge people to replicate their lives. So I think that needs to happen once they've got home. And also, people are quite defensive. Some people are quite prickly in the beginning, when you start asking them, where are you and what's the date and whatever. But once they get home and they start to realize actually something's not quite right, then they're more receptive to, I think, being assessed.
Any questions? Nicole.
Is it working? Thank you so much, Jenny. It was such like an inspirational talk to hear, particularly as a clinician kind of moving into academia and being a clinician that had questions about their practice and thought about how you could develop research questions in order to answer the questions that we have every day. And this is a population that we deal with here a lot at the National, because we have the emergency stroke unit here, which is a slight deviation from the normal pathway of other hyperacute stroke units, whereby you have A&Es. So we have really high numbers, or we get called upon as therapists to see high numbers of patients with a confirmed stroke on our emergency stroke unit who have really low NHSS, usually 0 or 1, for a bit of facial weakness, get called down to go and see the patient, have very limited time and resources. And it's really, like, as you said, really hard to really assess them and challenge them at the appropriate level to really inform ongoing referrals. I think we've got quite a low threshold for referring on. I think we're quite conscientious of all the hidden impacts of stroke, particularly around fatigue and challenges that patients might have where they look really well and able around return to work. And I think that's probably because we're very fortunate to have a VOT rehab service here at the National and are very aware of kind of the hidden problems that patients have about going returning to work. But I agree with you totally in terms of it, you know, all the intervention we do have to ESU feels lacking in worthiness in terms of an outcome of assessment. And what we typically do with having a low threshold, we do typically refer lots of these patients onto our community teams, and it just doesn't feel like the current stroke pathway fits these group of patients. The current stroke pathway is whereby patients are assessed as having ongoing therapy needs. We refer them to the community therapy team. They are hopefully seen within 48 hours, 24 hours by a community team, who often, again, the patients just don't feel like there's a problem at 24, 48 hours and then get discharged. So the input that we've had from an acute perspective actually results in very little beneficial outcome for the patient. So I think it's really important to kind of relook at the pathway for this group of patients, because a lot of resource that we are currently, it might be slightly more unique here because of our ESU, but we are putting a lot of therapy resource into that assessment, a lot of therapy resource into the ongoing referral. And we've actually had feedback from the community services that they're not terribly happy sometimes, and it'll be interesting if there's any teams here in the community now to get some feedback about those patients, because they are patients that they see as a one-off and then discharge. So yeah, I think it's an amazing bit of research. Hopefully pathways change as a result of it. And yeah, thank you.
14 years is what it takes. I've done the RCT, so not in my lifetime, but maybe some of yours.
Thanks so much.
Hi.
There we go. Yeah, great talk. Thank you so much. I just wanted to ask a little bit about the research side, I guess, and the great representation you were able to get with some minoritized groups. I think that, as you've mentioned, that's really, really difficult part of research sometimes. And you gave great examples, the Mosaic group, the cafe, and there was a web chat. Basically, how you went about finding those opportunities and those groups, and kind of how any tips you might have for researchers or clinicians to go about doing a similar thing, finding those opportunities, but also actually making use of them as well once you have found them.
I think it's a good question, because there's a lot of fatigue in the community from these groups, sort of underserved communities, where researchers sort of swan in, ask some questions, tick their PPI box, and then never come back again. So the communities that through Imperial College, they have this organisation called the Patient Experience Research Centre, and they had established relationships with the communities already, and the relationships were based on providing education and workshops to the communities on the topics that they identified as important to them. So stroke was one of them. And they said to me, don't talk about your research, just go and talk to them about stroke. So that's what I did. But that was when I learned like so many things that influence my practice now, just in terms of how I approach people. And also this thing around with the sort of communities where there's often a big family, the patient may be the non-English speaking person, they've got like young, like adult, English speaking kids and stuff. And those are the people actually that you have to get the consent from, and you need to go through, and you need to get buy-in from to agree to participate in the study. So, and often those are the people that I think researchers just avoid because it takes so much longer. And often it's not just one family member that makes the decision. You've got to check with the sister and the brother and all the rest. So it's, but yeah, your point is the communities want to get something from you as well. They don't want to just give their information. So it takes time. And with research, many people aren't funded to do that. And that's another thing, is also paying people for their time. You know, like as clinicians, if we were to start a group, the big question is, how would we pay people to come to the group? Yeah. So
That's really helpful. Thanks.
Okay.
Can I just ask one more question? Because I think when we did Enroll and the pandemic hit, we did a small group of a cognitive rehab group with a psychologist, and some of those are quite early stroke, some of them quite mild online. And I know that has to be digital. I just wonder if you've got any ideas of whether digital interface of online might be an opportunity to catch people in 4 weeks to see whether they are struggling with the return to work discussion, or whether there's any major fatigue, which was one of your two major things that came up. Because it might be that, I mean, it's difficult to get commissioning for Enroll, for instance, but...
Yeah, I definitely think that is one way that people could be followed up, and it's an efficient way, because it's not efficient to go to people's home. But if we want to be equitable, then the people who... We can follow people up that way who have access and know how to use all the digital stuff. But to be equitable, you have to go to the other people, and that's what takes time. Who aren't going to engage. And also, one of the interesting things, one of my study participants, he was sort of a 60-year-old man. He was very engaged with me, and when I asked him to be part of our group, our PPI group, he said, "I will only take part if it's online and we can have our cameras off." He said that the only person who knows I had a stroke was my wife, and I'm afraid there might be someone there that I know. So, you know, that was this thing of like feeling ashamed if you've had a stroke was something that was kind of completely new to me. And I feel like I've been working for so long, surely I should know it, but I didn't realize that some people feel shame and embarrassed that they've had a stroke. So they wouldn't want to engage in... So those people you have to go to one-on-one. And that's where the equitable thing, because the problem with many of the PPI groups is they, you know, people need to be willing to be outed in a way, make it public that they've had a stroke. They need to be able to get there. They need to, you know, we have a PPI group, and one of the women she has quite young kids, and the group's at 2, so she misses it very often because she's picking kids up from school and stuff. It's just really hard to kind of meet everyone's needs.
To be honest, someone behind you put the hand up first. There you go. Yeah, no, it's good for the steps. One step change.
Thanks, Jenny. I know you're a big advocate of this, so I'm sort of asking a bit of a leading question. But how important is lived experience in all of this?
Well, I think because I was a very experienced clinician, I'd like to say, when I started this. But everything that I thought, like how I thought the follow-up should be, was changed by the perspectives of the people with lived experience. So what I thought I knew, I kind of knew, but I didn't really understand. And so I think without lived experience, and there's so much research that just excludes that completely, and that's why they can't recruit people to studies, or they recruit the same type of people always, because they're not understanding the perspectives or the priorities of the people who've actually been through it. So yeah, it's important. And I'd just like to say, I'm very excited. We submitted 3 people from our PPI group submitted an abstract for a workshop at UKSF, the one where you could submit your own topics, and I just heard this afternoon that it's been accepted. So it will be a workshop led by people with lived experience, talking to the clinicians and researchers in the room about, you know, the barriers and all that kind of stuff. So I think it's going to be exciting. Nick.
So is one of the problems that we just don't have services to refer people onto? I mean, I remember my experiences of doing the kind of 6-week follow-up clinic I used to do here 15 years or so ago, and you see people, I mean, it wasn't often 6 weeks after their stroke, but it was in that kind of, there was that kind of clinic. And we didn't have a clue what, to do with these people, to the extent where you almost thought, I don't want to ask.
Well, that's exactly, I mean...
If you had a therapist with you, it might have been all right.
Well, no, exactly. No, completely. That's not how the clinic was set up.
No, we didn't have...
And I think,
She did a great job in actually, making sure that all of these symptoms were documented, and I was kind of terrified that she was picking up all these symptoms that we didn't know what to do.
Yeah.
Because there weren't any services. I mean, the answer is, in order to change that, you have to document the problem, right, which is what you're doing. But then that has to lead to some change where we're very happy to find out about these because we know what the referral pathway is. I mean,
it's not that people are...
Medical, in the broader sense, is easy when you know somebody who can fix the problem. It's that, I don't know, but I know somebody who can. And we don't have that.
We don't, and I mean, with the NHS priorities, care in the care moving from acute into the community, unless the money follows that, we won't be able to uplift the services that are in the community, because you're right, the services just don't exist. Because even with the follow-up that I did, when people flagged a problem and I made onward referrals, I kind of did it with my fingers crossed, hoping that someone would actually see them, because I knew that, in terms of their basic ADLs, these people were completely fine. This was not what the referral was about. It was the high-level stuff. And that one woman who said I could make a cup of tea, and, that's what it was an OT. He'd gone in and asked her to do that, and that was not what her problems were. She had much higher-level problems. So the problem, it's what you do with it. I mean, there are some people that would just benefit from the reassurance, the kind of normalizing of this, what they're experiencing, and that's enough. But there are people who need the VOC rehab type of services. The fatigue management. And, I mean, I don't know who...
Cognitive communication.
A
lot of those get really mixed, don't they? And then the relationship breaks down. And we see that even in our PLIM program, where it's really challenging. They're not ever referred. Same as cognition, isn't it? It's quite life-changing,
So just one other thing, because you mentioned in your outcome measures that you had some quantitative outcome measures of, you had the mock-up, for example. Did I miss it? Did you show us those mock-up results?
No, so I do have them. So I looked at between group differences, and I looked at within group changes and between group changes. And the mocker score went up, but at 12 weeks, the mocker score was still below 26, which is the cut. I mean, and the mocker is like as blunt as, I mean,
there was evidence of impairment. But
there was evidence of improvement, but still impairment. So in both groups, they improved, which you would kind of expect. But neither group had got to what would be considered, within the normal range.
So that's very powerful as well. So look, this person
just on a blunt tool.
Minor stroke, you're fine now, and actually you've got quantitative data. And also what was interesting with the quality of life data is that the physical health scores improved, but the mental health scores deteriorated, which kind of makes sense, because with time you start to realize, hold on, my life is on its head now. This is worse than I thought. And I thought I was lucky initially because I didn't have an NG tube in, and I wasn't sort of gurgling away in my bed. But,
There's a question up there. Oh, gosh, right.
Hi, thanks so much. I found it so inspiring. I work in ESD, and so often I hear people like with this imposter syndrome, like comparing themselves to other people on the unit, and especially talking about fatigue, they kind of almost feel like guilty to complain about it. And we need to like discharge people within like 4 to 6 weeks, but really 4 weeks. And I think it's really made me think about how to maybe like bring in health promotion, so that when I see people as on the initial and like everything is fine, I almost kind of get extra points for like discharging them like, at 1 week. But just thinking about maybe if I can like use that time to like, you know, address like their risk factors, look at their lifestyle, like, and I'm just thinking, would it be best to do it more as like a tailored individual intervention, or to look at more like a group program, like for all the people like on the ESD pathway?
I mean, I'm always a fan of tailored because I think the group, because of what I saw just in terms of everyone, so their perspectives and their priorities are so different. It's really interesting what you say, because obviously I don't work in the community, that people, that imposter syndrome, they spoke about that. But one of the questions that I ask now, because I'm just fascinated that so many people don't take their medication. You kind of know who they're going to, you can almost predict in many cases. And so now I ask the question, are you going to take your medication? And they often just say, no. And also the question of why, you know, why did you have a stroke? If you believe your stroke was caused by a curse put on you by another family or whatever, why would you bother with medication? Because that's not going to help sort out that situation. So it's that kind of stuff that I think we never ask about because we don't think about it. But I actually think that maybe we should be more inquisitive and ask those type of questions. I don't know what the answers are, by the way, but at least letting people talk about it. Great questions. You can have one.
Hi, Jenny. Thank you for a great presentation. I guess I was just thinking, so I guess you're saying that there's a group of people who they get discharged back, and actually someone with maybe moderate, more impairments actually then gets a community therapy follow-up, and this group is getting missed, and what can we do to safety net them? And I'm just wondering about therapists and GP centres, whether that could be a tool as well as the community services that are around, because so we're in the community and we have GPs that make referrals for stroke, but it's like a 3-month to 5-month waiting list. But it's that kind of capturing, because the GPs are already overwhelmed as well with lots of signposting, but considering maybe there's an area there, I'm not sure.
Yeah, that's a brilliant suggestion. I don't know how many GP practices have therapists, and I don't know whether they're very kind of like MSK or, you know, only see backs and knees and whatever. But yeah, I mean, you're right, we have to like think creatively and you know, and look at what's out there. I mean, there's a whole social prescriber thing, but it's like, it could be that for some people that helps to address a need, but I think it might not be enough for people with a sort of more cognitive presence, because it's quite complicated to support someone with that sort of who looks fine but isn't fine. Yeah. Question over
here. Hiya. Thank you for that. It was really, really interesting. I was just wondering about some advice about the kind of slightly different group within this group of those who don't make it to the HASU, because we're actually all from Homerton. We're not neurotherapists, we're from the emission avoidance team, but we often see, I guess particularly in Homerton, which is one of the most deprived boroughs Hackney, one of the most deprived boroughs in London, we get a lot of people through SDEC. So we see A&E, SDEC, the admissions ward, and then rapid response in the community. But we would be referred patients who have missed that window and are being sent home that day, and they are being seen by generalist therapists. And I mean, they wouldn't have intermediate care goals to send to what would be our 6-week therapy input. The next group is our ACRT, which is the longer, slower stream rehab. That's got like a 4-month, for neuro maybe 3-month, it changes, wait list. What do we do with these people? I don't know if anyone else.
Yeah, I mean, you know, it's a bit like some of the patients in the TIA clinic who aren't ever admitted. The GP refers them in, they do a scan, they're like, oh, actually, you have had a stroke, you have all these tests, and they go. They don't see a therapist, they don't have any cognitive screening, they don't have the full assessment at all. Yeah, I mean, I guess maybe the starting point is about making the therapist at the front door aware of these type of people who look completely fine. So it's not going to be can they get out of their chair and can they get to the toilet. They can do both of those things, no problem.
Yeah.
But it's about work, it's about caring for children, or if they're carers for elderly relatives and stuff like that. So maybe all that a therapist could do in that setting is just to say, sometimes after this kind of very small stroke, people actually experience these problems. And you might find the things that you normally do much more challenging for you. That's normal. And, but then the question is who do you direct them to?
Yeah, and I don't know, I guess the GP follow-ups aren't happening. We do have the neighbourhood groups within Hackney, I know, but one of them has a vocational rehab OT, which we could refer to, but again, it's so neighbourhood specific.
Yeah, and usually the waits are really long. And I mean, if we think of, we all paying mortgages, right? And if suddenly we stopped earning, we'd be fortunate because we were in the NHS, we'd have a nice long sick leave. But if after, 6 months or whatever, we're still not earning a salary, you lose your home, potentially. So, and that's what people are facing. I mean, people who, drive taxis as a living and then they can't return back to that for a whole month. They don't have a salary and they're the breadwinners. So yeah,
it's tricky. We do have an acute neuro team, but they aren't currently funded to reach into ED. They did tell us about this talk, so we've come along. I'm not too sure if neuro is here, but I think we will start tracking them to see, because it does feel like not fair that you have to be a certain level of impaired to get it, and then otherwise, we do our best.
I think the data around the return to work is very powerful, because that you can put a cost to that.
Yeah.
And kind of at the end of the day, it all, in terms of funding, it boils down to health economics of, is it worth putting a therapist in that supports these people to get back to work? What does it cost, and what's going to, mean for society? It's making those arguments, I think.
Okay, well, thank you very much. It's good to know at least it wasn't just us struggling with this as well.
So we do have wine and crisps for carry-on discussions with Jenny, but we want to thank you very much for coming today. And I'll say...